work because our service needs to be standard across the country, and they need to be able to train professionals to interact with the patients on a particular platform, not on 50 different platforms. Plus, of course, such multi-morbidity, there's no point having a diabetes system, because you may well have blood pressure or heart failure at the same time. And then we talked about the remote monitoring already, and again, my view on this is that it has to be part of the overall system. It's not something that a specific siloed company would be on the receipt of alerts to. We'd have to ensure that it was integrated with the whole service. So that's it. Thank you.
Thanks very much, Orla, and that's, they're actually helping Orla, and this is actually the mainstream HSE initiative to stay in shift left. I think there are actually real opportunities to work together. So we'll go with Michael, and then we'll go with John, and I don't know if Gwynne Morley is still in the room. Brilliant. Okay, so and then we'll keep going. Yeah, we'll get done as quick as we can. So Dr. Michael Sugrue, huge privilege to be working with Michael. Letterkenny is now the heartbeat of data-driven innovation in Irish healthcare. So over to you, Michael.
Thank you, Martin. I want you all to stand up, please. Just stand up, and I want you to point where you think you're more likely to get abdominal pain. Right upper quadrant, left, right, or lower. For a weekend for two in Letterkenny Hospital.
I'm Michael Sugrue, surgeon in Letterkenny. You can sit down now. Because this brief talk over the next 45 minutes, just joking, is going to talk about emergency abdominal surgery. Oh, if Martin gets that pain in the left iliac fossa, the left side, let's hope it stays left and doesn't shift. Because if it shifts, he's in trouble. So what we did in emergency surgery, Martin is going into Tullamore Hospital this afternoon with acute diverticulitis. How many of you in the audience have had a friend with cholecystitis, appendicitis, or diverticulitis? Hand up. 100,000 patients are admitted annually to Irish hospitals, 15 million in the EU. The chance of Martin dying from his perforated diverticular disease is 10%. One of the highest mortalities of conditions in Irish hospitals. Do we have data on this? Not really. And this project was set up 3 years ago with EU funding, and I'm privileged to have worked with cross-border and Scottish partners on this project. And what we did was, we set up a digital database supported by Martin and Digital Transformation in the HSC and Michael Broderick. We enrolled over a 3-year period 6,000 patients in our hospital alone in wee Letterkenny. So you can imagine the volume. That would have been 300,000 patients in Ireland. What we did then was we actually created a data dictionary to define this. We set up key performance indicators, 50 of them, in the 8 common conditions that give you that pain in your tummy, which is either your gallbladder, your appendix, your diverticular disease. That then allows us to design decision trees. In addition to that, we undertook research to complement the clinical picture. So what we have done, it hasn't been done before. Believe it or not, there are fantastic registries in cardiology, neurology, breast cancer, which I also do, but in emergency general surgery, just because Martin's going to go in and 10% chance of dying, it doesn't really matter that much, does it? It's not cancer. So what this project did, and it's available, our 350-page report was published yesterday, and it's available on Donegal Clinical Research Academy, dcra.ie. You can download the PDF. But what it's done, it's opened the future. Working with Martin is just absolutely fantastic. We're working with TCS, Medtronic. It has opened up the window for when you potentially get that acute gallbladder problem. We've identified, for example, that we're outside guidelines in certain conditions. Other conditions we do really well. As Orla said, we can create for a health insurance gap analysis, or for the public sector either. So it's a wonderful opportunity for us to have worked with digital leaders to allow us to transform your care, your family's care, your children's care, and your mother's care. The report made 10 recommendations. I sincerely hope that the leaders in this country will take them on board. Because if they do, they will save roughly 600 lives in Ireland a year and 12,000 lives in the EU. It's wonderful to be here, Martin, and I really enjoyed your previous speakers. And my 45 minutes is up now. Thank you.
We are going to employ Michael as the timekeeper for the next event. I was presenting at his launch event on Wednesday. I went 5 minutes and 1 second. Said stop, next speaker. So Michael, we need you next time. So John is back on stage, and if we could switch to his screen, John will be able to explain all. And Charlie Larkin, if you can get ready as well, Dr. Charles Larkin, to come on the stage, please. So we go with John, Gwynne, Charlie, and we keep going as long as there are people in the room. And by the way, the supplement from the Irish Independent is available. Some of them are passed around, but they're available on the way out. And features, for example, Durham View is another company that we've worked with, another 10x example that we will feature at a future event, and so on.
Super, finally. My apologies for that, folks. So this is Gordon Spray. He unfortunately had to leave, but I just want to bring you through the virtual reality of his MRI scan of his brain that was done last Wednesday. And we did a variety of sequences. This is a slicer, and this is Gordon's head without the hair. And I can grab it like this. Around the room, and then what I can do is interrogate it. So I can take the slicer, make the slicer bigger or smaller, and I can grab it and then actually put it into the side of his head and look inside. So we're now inside his head, and that structure there in the middle is his brain stem, and that's his corpus callosum, and that's his right frontal lobe just there. So what I can do then as a physician or a patient or somebody planning surgery or indeed doing it is that actually I can have a 3D interactive ability to view the brain, and on top of that then I can pull up other data files that the patient would have had, which I think are down on this side of the stage, because everything actually is virtual. Where is it? Anyway, I won't proceed anymore, but I think you can see there the ability to actually look right inside. So apologies, this was a bit of a complex multi-audio-visual presentation, but hopefully you've got an idea of the power of it for teaching, discussing, planning, and actually ultimately intervening. And this can be done for the brain, the heart, the liver, the lungs, any complex organ to assist and essentially make things better and faster. So that was essentially a summary of what the second project in collaboration with Microsoft and the Molecular is. And obviously this is where we're heading. We want to end up like the man on the moon and be European leader by 25 and global leader by 2030. And I think what the last 2 weeks have really shown is that by us coming together in terms of, in this case, which is the HSE, and Blackrock Health, Siemens Health and Engineers, Molecular and Microsoft, we really get this super collider effect of actually achieving a huge amount in a short space of time. And again, it's all centered around the patient or the family in this case. So just to highlight highlight again really the importance of the quadruple helix and how it can be a super collider and that we're all better together. So thank you for your time. Apologies for the technical.
Thanks so much, John. And that was done in 2 weeks, and that's a brilliant example, from the innovation field of what's called architectural innovation, where you pull these different components, put them together, and the sum of the individual parts or the sum of the whole is much bigger than the individual parts. Really delighted to introduce Gwynne, Morley, and Gwynne and I had a conversation about 1.5 years ago, which I still remember as fabulous. And what IQVIA are doing is a brilliant example of the data-driven innovation pattern, and the data-driven innovation is going to open up enormous opportunities. So I'm really looking forward to hearing about this example. So welcome, Greene.
Good afternoon or late evening, everybody. Delighted to be here, and thanks to Martin and his team for the invitation. As Martin has mentioned, we're actually IQVIA's human data science company. We're actually like a global provider of analytics, commercial tech platforms, but actually the bulk of our business is clinical research. So what it is the integration of the study of human health combined with breakthroughs in data and technology to really improve the outcomes for patients and citizens, as we've all heard here today. As I said, my conversation today with you is really around the whole data piece. We don't have some of the futuristic platforms or digital innovations that we've seen today. But I guess, I think because of the pandemic and COVID, it's well documented the impact it's had on the health system. And I think now it's recognised that health is high policy, but to actually influence policy, you need data, you need health statistics, and you need data. And I think ICGP conducted a study there in 2019 where they were looking at how to make every consultation count. And basically what they had identified, in some of our peer markets in other countries like Australia, the UK, Netherlands, the primary care data is a very rich source of patient information and data to support chronic disease management. Unfortunately, when they interrogated the Irish primary care data, we didn't necessarily have that rich source of data. There was a lot of gaps and there was a lot of information missing. It was difficult to extract. So I guess in preparation of today's conference, what we did, because we sit right in the centre of the healthcare data and insights in Ireland, we actually have patient longitudinal data within IQVIA in Ireland, where we can look at treatment patterns and treatment dynamics and cohorts of patients. So particularly in line with the whole chronic disease management framework that is part of this Launching Care programme. So what we are able to do is actually break down based on co-prescription data, but also the treatment dynamics, look at these cohorts of patients, get some indicative numbers, and then we can overlay that with regional, breakdown of the regional areas like the community health networks that Dr. O'Reilly had mentioned earlier. And we can look at the various different prescribing patterns, but also see is that compliant with our practice guidelines, but also best practice across the European market. So what we did as part of preparation for this conference today, we actually took like a proof of concept study where we went out and looked at a couple of the primary care centres and we analysed their data just to see, was there gaps? Could we predict maybe patient registries, the number of patients that were on those registries? So we took heart failure as an example of this. And I think most of you, probably the last time this was looked at from the cost implications of congestive heart failure, it was a study done in 2015 by the Heartbeat Trust Fund, the Irish Heart Foundation. And basically what they identified that the cost of congestive heart failure in Ireland was costing 660 million, but 47% of that cost was related to hospitalisations. So if you could imagine that if we can address the hospitalisation, it won't be just 10x that you can actually gain from those efficiencies, it'll be much greater multiples of that. And from our initial analysis, and basically this was one day of patient analysis in the primary care centres, we actually identified 50% more patients to go on the congestive heart patient registry. So it was a significant number of patients. The GPs all felt that they had complete registers, but we actually identified at least 50% more. We also identified that 50% of the patients were on long-term loop diuretics. And if you look at the ESC 2021 guidelines, there's very poor evidence for the use of loop diuretics in the treatment of congestive heart failure. And also, there's no random controlled trials conducted looking at the mortality and the morbidity, the impact of loop diuretics on the morbidity and mortality. So quite significant information we got just by one patient, one day of patient analysis in those surgeries. The other thing that we identified was that a lot of the diagnosis was observational due to backlogs with echoes and also with BNP lab resource. So again, that's a challenge because then we can control the patients, keep them left, as Dr. O'Reilly says, so that they can stay left in that treatment once we can identify them, rather than them presenting as hospitalizations. Another area that IQ was very much involved in, and it was again linked with the pandemic. We're a founding partner of DataCan. I'm not sure if everybody is familiar with DataCan, but it's the UK Health Data Research for Cancer in the UK. And it's led by Professor Mark Lawler. He's the scientific director based in Queen's University up in Belfast. And actually part of that DataCan is to get access to real-time data and real-time analytics. And they were able to identify in the early stages of the pandemic that based on the 2-week wait period information that was coming through, there was a 90% drop in endoscopy during the pandemic for colorectal cancer. Now we all know that if colorectal cancer isn't addressed earlier on, the prognosis isn't very good. So what they did was they used data from fecal immunochemical testing to actually triage and prioritise those patients. And as a result of that, they reckon they were able to save in excess of 90% of excess deaths, but they also were able to save 80% of endoscopes that weren't actually required as a result of that fit. So basically, there's an opinion piece by Mark Lawler, and what he's saying is that access to real cancer intelligence really requires, fast, available, real-time data. And I think a similar sentiment was as a recommendation in the cancer, the impact of COVID on cancer in Ireland. It was a paper published there just before Christmas with the Royal College of Physicians of Ireland in collaboration with the National Cancer Control Programme and the NCRI. And one of the key recommendations of that was that the availability of integrated and accessible data is really, really key to have a very robust cancer intelligence system. So I think, although we're not coming with some kind of major innovation, but what we're really driving towards is to have that availability and access to data, because that is very, very key. And I think the exciting part of all of that is that you can have really a superior population health system as a result of that, as a result of better insights and better data, which will fundamentally drive better citizens' outcomes and better treatments for patients as well. I'll also just mention another project that IQVIA are involved with, and it was actually launched on the 1st of March in Trinity there, Precision ALS. It's actually been led by Professor Orlaight here in Ireland. It's a 10 million Irish-led project. SFI funding is contributing 5 million of that, and the additional 5 million is coming from industry. We're one of those industry partners that is involved in that. But I'm not sure, ALS is more commonly known as motor neuron disease, and but a lot of people aren't aware that there's a lot of different variations to the disease, and the progression patterns are very unique. So actually, to get some information and to understand the disease better, you need a lot of data. So TRICALs from Europe are going to contribute a significant amount of data, which can feed into this Precision ALS platform. And if they succeed to do that, fundamentally, it's going to be a life-changing, hopefully, disease treatments for those patients. And the beauty of all these things that I've described here, they're actually therapy agnostic. So if you can actually get it right, you can apply that to any therapy across. What we did with the congestive heart failure project in the primary care practices, it could be applied to any chronic disease management. If the Precision ALS platform is successful, it can be applied to any therapy. So I'm quite excited about what's happening today. I feel we're going to be more of a collaborator in a lot of the initiatives and that is there. I'm really delighted and happy to support anyone who wants to chat to us afterwards to see can we support them with more insights and more data. And I really feel as a result of this that we're going to have a new primary era is going to be born as a result of all of these initiatives. So thank you. Thanks, Mike.
Thanks so much. The power of data, you know, Pareto applies here, 20% investment, you get 80% return. So this is an area of real high priority. So we'll keep going until people start going. So Dr. Charlie Larkin, then we'll go to Dr. Matt Barrett, and then we'll keep going. There's a few other people, and then Professor Richard Costello will close. So is Charlie here? Brilliant. Okay. Charlie was special advisor to Michael Hardy, who was chair of the Health to Office Committee and did absolutely fantastic work at Charlie's talk. And we've had all parts of the ecosystem represented here, and Charlie is our policy lead, is the vice chair for the Irish Digital Health Leadership Group, and we're also working with Charlie at the University of Bath around the application of digital to healthcare in Ireland. So Charlie, please.
Thank you, Martin. I don't know if the representative of the British Embassy is still around here, but if he is, I'd like to see him afterwards, just to have a chat about the project we are doing at the University of Bath. So, I'd actually like to bring people back to one of the great Irish traumas, Saipan. And I'm bringing you to Saipan because, first of all, it will wake everyone up at this hour on a Friday, and second of all, because it's about the pitch, and the preparation and the condition of the pitch. And in policy, that's what you tend to focus a lot on. I've seen a lot of wonderful things here. I got to know Martin not arriving in a Ferrari, as Lee was describing it, but arriving on his bicycle to Leinster House on many an occasion, trying to convince the policy community to develop that pitch. And that's really the problem. You know, we heard about, you know, beating that elephant into the room, and the elephant in the room is acceptance of failure in the political system. Right now, pencils do not come with erasers in Leinster House. If you do something wrong, you will be in front of the PAC and you will suffer horribly. And everyone knows that, and everyone responds to that incentive by being very conservative and not attempting change. But Leinster House is a place where things do have to change. We have to change how we do procurement. And while Philip Lee can find some very interesting loopholes, ultimately when we're talking about developing that pitch, we have to do big procurement projects, which means that we don't have to look at least cost, we have to look at what achieves the best outcome for Irish citizens. And that's really at the core of all this, is talking about the Irish citizen. In the work that we're doing with Martin and with the Digital Academy at the University of Bath, where I'm the Director of Research for a Policy Institute, is that we've received a large grant from the Made Smarter Innovation Group for people-led digitization. And at the core of that is the idea of solving the problem that Robert Solow described with economic growth. I see computers everywhere, but not in the productivity numbers. Really, that is about changing how people do things. Right now, we do exactly what we did 60, 70 years ago, but with the technology of computers. We don't change how we do things. And that's really what we're trying to do with the People-Led Digitization Project, working in concert with Martin, is actually making people be digital about their business practices, as opposed to doing with computers what they used to do with typewriters and filing cabinets. And that means talking about really novel things, about universal enterprise architecture in hospital environments to really optimize hospital usage. Talking about business process management, talking about theory of constraints. Linking all of these things together to change how we talk about and work with healthcare, and actually make it about healthcare, not about sick care, which is really where we're residing right now. And that's the only way we're going to really deal with improving those cost curves. We know that they're never going to be going downwards, we just need to decrease the slope of those curves over time. And a lot of what Martin has been doing over the years has been about that. So really, what my side of the conversation is about taking that policy dimension and trying to find a way in which we can change the narrative in government, change the narrative amongst policymakers, where health is an area where you have a financial black hole, where you have a litany of failures and tragedies, and make it more about, well, this can be somewhere where Ireland can achieve things, it can be novel, it can be agile, but most of all, it must learn that it has to have in place an adequate pitch, and it must be able to learn to live with and accept failure and develop from it. And now, final remark on this is, today I travelled down from west of the Shannon, from Sligo. Google sent me down the N61, and I was listening to part of the beginning of this conference through a very, very poor and spotty broadband network over 3G. If we are serious about this, if we're going to actually roll out in a situation in the way that the New Zealand Canterbury system has said, that there is never a bed crisis, because there's a bed in everyone's home, you're going to need to have broadband and high-speed broadband up to 5G ubiquitous throughout the country. And that you drive down a national road and you can't even keep up with a telephone dial-in, let alone a full Zoom link to get to Tullamore, means that we have a lot of very basic work to do. And at the core of that still remains issues of data. And the previous speaker mentioned a lot about data infrastructure. You have to invest in it. It's not sexy, it's not attractive. You can't look inside people's brains with it necessarily, but you need that data infrastructure and that data legislation. One of my abiding memories was sitting with poor Martin for 3.5 hours in a room while we were told the many, many reasons why we can't have an individual health identifier in this country. We have to move on from that and just grasp the nettle and actually deal with these big basic data infrastructure problems. That Ireland doesn't have that already solved, where countries have had it since the 1950s, really is an example of places where we can have quick wins and easy wins and necessary wins for that basic infrastructure. So going back to Saipan, Roy Keane was right, it's about the pitch, and we have to make sure that the policymakers know that they have to put in that effort now and into the future. So with that, it's a great day so far, and it's been great working with Martin so far, and I hope that if any of you do want to work with the University of Bath as part of this people-led digitization project, it involves a large consortium of different digital actors. The HSC is part of it with Martin. You also have the Bowie Corporation working with us. So if you would like to work with us on this project, it's a 5-year project, so please just get in touch with me. Either nobble me in the corridor, I'll give you my card, or Martin can send on your information to me. So thank you very much.
Thanks, Charlie. So I think Dr. Matt Barrett is next up, and then hopefully Professor Richard Greene. I know Richard's got to go to Cork and coming from Dublin, so hopefully Richard, you can be next up, and we'll keep going until people start to throw tomatoes at Matt, thanks very much.
Alright, thanks very much everybody. Matthew Barrett's my name, one of the consultant cardiologists working out at St Vincent's University Hospital and the new integrated cardiovascular care hub out in Bray. I'm going to be incredibly brief because it's a nice day outside and none of us know how much sunshine we're going to get for the rest of the year, so none of us want to waste a spare minute. Just on the point of our last speaker, the HSE procurement absolutely needs to change. I just spent about, I'd say, 2 hours of today writing various emails explaining why the echo machine the HSE wants us to buy will be obsolete in 6 months and keep getting the same reply back. So headbanging kind of stuff. But on the point of the integrated care hubs, and hopefully you'll see them kind of coming to prominence now over the next few years as they roll out across the country. It gives a really, really good opportunity to basically design from the ground up an ideal e-health centered model of delivery of chronic care. Now we've mentioned a lot already about heart failure monitoring, symptom control, blood pressure, all those kind of things. So I'm not going to, we have a huge amount of stuff on that. I'm going to wait for, when it's ready for prime time, really to talk a little bit more about it, perhaps in future meetings, which I hope we'll be having regularly from now on to keep ourselves updated as a nationwide unit on our progress in health. What I might just touch on briefly is what Martin had mentioned earlier is about the use of rhythm monitoring devices, and in particular focusing on the cardio-mobile device, which we're trying to get integrated into our new care pathways out in the community. But when we were setting up our cardiology unit, we had a very detailed discussion with our GP colleagues in the area. That comprises South East Dublin and the Wicklow area, Community Health Organisation 6, and they basically said that AFib palpitations really were a huge part of their workload. I can see that filtering through into tertiary hospitals, about 30 to 40% of our referrals are undifferentiated palpitations or questions about arrhythmia. So, how do you take those out of intermittent monitoring with Holter monitoring, which we know from the data has very, very poor pickup rates, and it's often described as like being like going to the dentist when the patient has the monitor on, they never get their symptoms, and there's always a question as to what's going on. So I just brought along a little example of a device that we're using. Now, some of you might have seen the CardioMobile devices before, the AliveCore devices. Even over the last 2 years, I've been recommending patients just to buy them themselves for 100 quid on Amazon or whatever it was. They can take their traces and bring them in just to take a look. Basically, I don't know if you can see this, 2 little electrodes in front. What you can do is if you want a quick rhythm strip, you put your 2 fingers, one in each hand, down to that, 30 seconds, and it gives you a nice little ECG printout of a rhythm strip from lead 2. So you can get a feel for, is the patient having atrial fibrillation, ectopics, all those kind of things. Very, very straightforward. What's new is it's quite a nice feature. I've been trying it out around the wards actually just in the last few days with some of the nurses and the patients. On the back there's an electrode. Any of you who are cardiology nerds like myself know that if you have 3 electrodes, you can create what we call Einthoven's triangle, using some part of the left side of your body in addition to these 2. So they recommend that you maybe roll up your trouser sleeve, or you put onto they also recommend crossing your ankle over onto your knee and putting it down, so your 2 fingers. I'm not going to put my leg up on the lectern here, but I could if you really wanted to. And that gives you a nice 6-lead ECG. Obviously, you have 3 electrodes or 6 vectors, so you get a nice 6-lead ECG. So really, really good data. But we're going to try and work towards it as part of our offering when we start opening it, get up and running, is almost having a library of these. Like the patient will be referred in with their symptoms, be it palpitation, suspicion of atrial fibrillation. They'll check out one of these devices. They'll take it home for a period of 6 weeks, 3 months. We'll have a physician-controlled back end, so I can log on, similar to some of the monitoring systems we saw before. I'll log on, I'll see what tracings have been recorded. There'll be a certain amount of self-monitoring or artificial intelligence that will dictate this is likely to be atrial fibrillation, this is likely to be a significant arrhythmia, or hopefully for most patients they'll say totally fine, nothing to worry about. The patient will be able to check themselves, they'll be able to see are they having the arrhythmia. If they're having symptoms, they can label one as being a symptomatic episode and send it in for monitoring. I can reply to it directly and say all fine. At the end of the monitoring period, hopefully the patient will then send their device back in either with a diagnosis made or a significant diagnosis excluded. So really you're taking away 1, the workload of diagnostics and the non-invasive cardiology departments in the hospital, but 2, talking about really expanding this out to a much larger patient population than previously would have been possible. So that's kind of it, very, very groundwork type stuff. There's a lot more going on in the background. Obviously, I'm not going to take up much of your time, but just so you know, there's a lot coming down the line, and keep an eye out for your community hubs because there's a lot of exciting stuff going on. So thanks very much, Martin and the team.
Matt and Ken McDonald have been sort of fantastic partners. We're pretty good at digital innovation. We're actually lousy at timekeeping, but we'll address that in the future. So real pleasure. Digital health is easy to talk about, but it's much harder to do. Professor Richard Greene has actually done this in the CUMH in Cork. And I had the privilege of taking a tour with Richard about 2.5 years ago. One of the nurses said to me, well, when I saw Professor Greene arriving at 7 p.m, I don't know if it was a Friday evening or Saturday evening, and taking the computers out of the boot of his car and bringing them on the board, I knew this was serious. So Richard is the CCIO, he's very influential in the HSE, and he's always a good sparring partner as well. He doesn't agree with everything I say, and that's fine, but we have a good back and forth. We eventually get into a position we agree on. So thank you, Richard, and thanks for being here all day. We've got to go to Cork.
Thanks, Mark. Thanks. I'm not going to keep people very long, but I've really enjoyed the day. I think it's very exciting, and I think the one thing that the one word I would take out of today is together, because I think we need to do this together. I joke with Martin every time I see him that I wish I was. I don't have a lot of the skills he has, absolutely not. But I wish I was in this end of digital health, which is the nice kit, the fun stuff, and all the rest of it. But sadly, I'm not. So I think we have to think about this digital health thing as a bimodal approach. So we have the tech and everything over here, and we're doing all that work, and it needs to be done, and it needs to be supported, and we need to measure it, and we need to work out which of these pieces of kit are actually going to do something that helps us. And today we saw a lot of systems that actually would be really valuable for person health. Really, really valuable for person health. keeping people, maybe not this year, maybe not next year, but in 5 or 10 years' time, that they've looked after their health so well through monitoring and everything that we won't be seeing them in the acute services. So we're moving them way over and keeping them over there on the left. I'm unfortunately, the learning that I got out of the process that I was involved in is, and everyone talks about people, process, and technology. And the biggest learning I got out of that, I started off thinking it was the technology, I ended up knowing it was the people. And so that's where I am. And there's two groups of people. We have the public, who is the person, or the human being, as Russ said this morning, and the patient. And then we have the staff. And so we have to bring them along as well, and we have to support them in every way we can. And that involves a lot of education, and for the last couple of days listening to this in another process, and we really need to be considering that, because not everybody is the kind of leaders that we've had here today in terms of doing this, and we need to bring them along. Sadly, where I end up is much more about, in the last couple of speakers, about data and about the pitch that was being mentioned. I actually feel that my role is very much around this is actually foundation. So it's building some of the foundations. And the single foundation that we have to build and get right for once and for all, and just stop talking about it, it's actually going to be hard work, and that is, do we know that this is the right person? As long as you care throw it out there as the right person, right place, right time, everyone talks about it, do we know that this is the right person? So we've got to get that system of record absolutely right. Then all these processes and all these technologies can actually link on. It's very easy to throw the IHI into them or whatever we put on it. But we need to make sure that it links to the IHI in the system of records. When I turn up in Dublin and I'm having a problem and end up with a doctor or whatever, they know who I am. And the other thing is data and data standardization. We have multiple silos and systems of data in the health system at the moment. You heard earlier how poor some of it is, that we don't have standard diagnosis and stuff like that. So, that is really, really important. We begin to build the standards, so all these systems begin to fall to the standards. So that's the piece that I'm going to be in, Martin, and of course working with you to do the rest. But I want people not to walk away thinking that we can do it with just the technology. We need that broader thinking, and I know you know that, and we're together on that. So I'm just going to leave it at that.
Brilliant. After so many people we still need to hear from, is Maeve McGrath here still? Maeve, would you come up and just say a couple of words around the capability maturity framework as a roadmap? We want to go to Helen, we want to go to Marcus and David and Jared, and but we're probably going to have to cap it very soon, Loretta. So,
do you want to explain what it is first?
Okay, so the Digital Health and Wellness Capability Maturity Framework, we're working very closely with Marcus Helfer, Professor who's the head of the Empower program that Philip Nolan mentioned, is a level or 5-layer maturity model for looking at how a country actually builds its capability. We have support from Huawei, from Jared and David, from Ronan and Medtronic, Maeve and Roche and Brian and Cisco, and we also people like John are part of our group, Donald Bailey, and we're PwC are onboarding at the moment. But we are going to share the very early results in 2 weeks in Barcelona with Elizabeth Ticeward, and we've built out sort of what does level 5 and level 4 look like in terms of a world-class system. So thinking about, we have what we call a dynamic capability model, and we have 4 what we call macro capabilities. But just taking one of them is a sustainable economic model for your health budget. So today, for example, we spend 3% on preventative healthcare and promotion. We'd like to see that at 9%. We spend 1% on digital, or less than 1%. The NHS spends 4%. If you're world class, you want to be getting up to 5 or 7%. But in terms of the total budget, our estimate is we could reduce the total cost by 15%. So 15% of 20 billion is a lot of money. So we're looking at that. Then we're looking at, in terms of capability and value-based healthcare. So the ability to screen everybody in the country, as Orla said, find these risks early and detect them. The ability to give a personal electronic health record to everybody in the country. These are in the model. So we work actually every couple of weeks as a research group, and I'm really grateful to Maeve and others who actually put in the time. And actually, we're going to have a little holiday in Barcelona for a few days, working with Elizabeth, about 100 other people that are exploring these themes. So I'll hand you over to Maeve McGrath, who's been a fantastic supporter. She's the lead for digital health in Roche, and has been a brilliant sort of sparring partner, and really was the inspiration of Leapfrog. Maeve and I had a conversation, and she presented, and then we thought, okay, let's adopt this nationally. So Maeve, please.
Thanks, Martin. Well, initially we were going to be on a panel, and I was going to say why Roche did it, or got involved with the capability and maturity framework. And the main reason for that is that we have this 10-year ambition to be able to deliver 3 to 5 times patient benefit at half the cost to society. And I think when you hear all the conversation today about outcomes and right patient, right time, right place, it's very obvious that we're in the right room and the right company. And we see that the capability and maturity framework is a way to be able to measure that, to be able to say, well, what value is digital health actually giving? What's the impact? And how do we assess that? How do we move from level 1, which is ad hoc, to level 5, which is optimizing? But I think the most significant thing about this innovation partnership is the way that we're approaching it. And I had a conversation earlier on this morning with the other consortium partners. And really what we were talking about is this ecosystem approach. And you bring in these different perspectives. So we have the pharma perspective, we have the telco perspective, we have Cisco, we have Medtronic, and then we have the academic. And when you start to bring these uncommon partners together, you create new value. So how do we create this value together, and how do we deliver on it, and how do we realise the potential that is really here for Ireland? Because when you look at what we have as a country, in terms of the world's life sciences and tech companies here, we have all of the collective brain power. So how do we work together to be able to deliver on that, and how can we use a tool like the capability and maturity framework to guide us, and to make sure that we're making the right decisions, and we're investing in the right technology, and we're identifying the opportunities that can improve those outcomes for patients. So thank you, Martin, for the opportunity.
So I think we have to close. I'm really sorry, Loretto and Helen and everybody else that was here. We're going to have Professor Richard Costello speak, and then we're going to run the Martin Shanahan video. Martin Shanahan is on the road, and he recorded this yesterday, just came in last night. It's fabulous. We will be posting it. It's really, really strong message of support and what we can do together. The only way to describe Professor Richard Costello is he's the Beckenbauer of clinicians in Ireland, and we have clipped 90-second conversations about once every 2 weeks, and we fire 90 seconds of information, then Richard goes back to saving lives, and it's such a privilege. A lot of what has happened here is because Richard had faith in us in that first week of COVID, and it was absolutely remarkable, and deeply indebted. And Richard is working with us as part of the Digital Health Leadership Steering Group, and once we mentioned Richard's name, like Philip Nolan, I'm there. So he said, is Richard really coming? So he's here, so thank you so much, Richard.
Well, thank you, Martin. I think I collected the words that were used today, and we heard care and citizen a lot. That was in third place. In second place, we heard data. But I think in first place, what we all heard was Martin. So I think we should give Martin a round of applause for organising this. And I was trying to think of a word that would capture Martin, and I was somewhere between the guy in the James Bond movies who's always got a new gadget, and the guy in The Wizard of Oz who's behind the curtain matching up something out of nothing. I think he's both, and congratulations, Martin. And thank you all for staying, you're amazing. And good night.
Wow, that was brief. What a way to close. That's style. So our next steps, we're going to publish a list of 10 recommendations. We will be presenting to the board, or Kieran Van, hopefully Paul Reid, We also hope to get an opportunity to present it to some of the senior ministers. So that will be the next step. We will put those suggested recommendations together and circulate. Thank you all so much for being here and for staying so long. It has been great. The friendliness and the altruistic nature of people here is fantastic. Everybody wants to contribute to the greater good, so I'm really indebted that you all showed up, and we're all doing wonderful work together. We could have done double the amount of presentations and demos, but hopefully we've proven, as Pastor McDonough said, show me the proof. I think we have lots of proof. So thank you, Richard, for that closing. Thank you all, and we'll run the Martin Shanahan video, and we will hopefully see you again soon. Have a great weekend.
Hello, I'm delighted to participate in this event. Ireland's new digital health strategy is designed to leapfrog Ireland from a digital health laggard to a digital health leader, and in doing so, transform health outcomes and economics. The strategy is unique in that it is not just a health strategy, but also impacts enterprise and sustainability. I am pleased that IDA, through Michael Owen and Rachel Shelley, have been working with Martin Morley and the HSE digital transformation team to help shape a national digital health strategy for the future. Remarkable progress has been made by the HSE digital transformation team since its establishment 2 years ago. Using the open innovation approach, the HSE now has a network of digital living labs traversing the country, and I'm delighted that many multinational companies are getting involved. The adoption of digital health technologies during the COVID pandemic has helped to save and improve lives. The Living Lab approach is an exciting and important selling point for Ireland as we promote Ireland as a location for collaboration, innovation, and investment in digital health and life sciences. Ireland is well placed to capitalise on advances in healthcare technology. As healthcare provision evolves rapidly, Ireland's vibrant enterprise base of life science and technology companies has all the necessary components to build on next generation manufacturing, product development, and digital innovation. Ireland has the potential to become an exciting digital and connected health hub, a testbed for ideating, developing, piloting, and rapidly commercializing future medical technologies, digital health solutions, and services. The Living Labs are an example of this vision in action. Ireland has a long tradition in medtech. 14 of the top 15 global companies have operations here. We are Europe's largest medtech employer per capita and a magnet for skilled talent from within Ireland, the EU, and beyond, working on cutting-edge technology, research, and product development. Ireland's wider life sciences ecosystem also includes strategic operations for 9 of the top 10 biopharma companies. 9 of the world's top 10 technology companies are also based here, creating a rich base of cross-cutting talent and deep innovation capability. Ireland has a terrific global reputation for life sciences and technology. Harnessing the opportunity to accelerate Ireland's position as a leader in digital health will involve close collaboration across our ecosystem of multinational companies, SMEs, academia, and government. Our FDI base spans the world's leading diagnostic, cardiovascular, neurovascular, orthopedic, vision care, hospital products, and diabetes companies. 75% of medtech companies are doing R&D in Ireland and are global centres of excellence in their disciplines. Our technology companies are industry leaders across enterprise software, AI and data analytics, blockchain, cybersecurity, and Internet of Things, all key technologies driving the next wave of digital transformation. Irish startups have an excellent global reputation also, with many actively partnering with global multinationals to enable connected devices and disease management solutions. Our globally respected research centres focus on multiple areas within connected health disciplines, from materials and microelectronics to software, data, and AI. Tapping into this talented and diverse academic capability, we can be at the forefront of intelligent medical devices and solutions. Ireland's size and infrastructure means that all three critical elements of the ecosystem have easy access to each other. Furthermore, there is government support in the form for the grants, or the tax credits, and the Disruptive Technologies Innovation Fund, designed to drive collaboration across the ecosystem. If we can align our ecosystem and collectively work together to drive innovation and collaboration within our health system and the technologies that transform the health system, Ireland can be a true leader in digital health. Today's announcement of a national digital health strategy reinforces that need to work together towards a shared vision of better healthcare, enhanced patient experiences, innovation and enterprise growth. To transform the Irish healthcare system requires a whole system approach with the support and engagement of clinicians, government agencies, universities, large and small firms and patients. We can radically improve healthcare division. IQVIA will take its part in supporting that engagement and collaboration. Again, I commend the work of Martin Curley, the HSE Digital Transformation Team, and the many organisations that have contributed to the development of the Digital Living Labs and the new Digital Health Innovation Hub in Tullamore, which I look forward